This is EMTV. I am your host, the delicate Dr. Daniel Holler. We have quite a show for you today. But first, I want to talk about graduation season. We have a couple of our own graduates coming up, but having crossed the imaginary threshold into attendinghood, having exactly zero more knowledge than you had the day before, having completed the minimum necessary requirements to be an emergency physician. Let's take a look at some of these graduates who did it right.
If you want to change the world, you're at Georgia Tech. You can do that. If you want to build the Iron Man suit, you're at Georgia Tech. You can do that.
Rachel Michelle Hutch.
We can do that. I am doing that.
All right, welcome back. Let's get on with the news.
EMTV News.
The CDC is reporting a drug-resistant strain of Shigella that is both resistant to azithromycin and Cipro. The CDC is recommending meticulous hand washing, so don't just put your hands in some water and pretend to wash your hands. You know you do it. Come on, you know you do it. New American Heart Association and American Stroke Association guidelines for spontaneous intracranial hemorrhage will be published in this July episode of Stroke. The guidelines recommend rapid neuroimaging, of course, appropriate factor and platelet replacement, vitamin K if necessary, lowering blood pressure to 140 will be safe in the hypertensive patient, and glucose and seizure management with anti-epileptic medications. The Annals of Internal Medicine, thank you, are reporting that bouncebacks to the emergency department are twice as more likely than previously thought, or if you're Dr. Turner, at least 3 times as more likely. They report that skin and soft tissue have a 23% chance of bouncing back with a 12.9% admission on second visit. Abdominal pain, 9.7% chance of bouncing back with a 29.9% chance of admission on revisit. And they also found that back pain had the highest bounce back to a different emergency department, with 7.8% bouncing back, and of those, 41% presenting to a new emergency department. We have quite a show for you today, so let's get it on.
You may recall that we've kind of created a few-step algorithm, a two-step algorithm in terms of distinguishing STEMI versus pericarditis. And this is what I always recommend that you do. Step number one, look at the factors that rule in STEMI. And if you come up with positives, you're done. You've got to call it a STEMI. So is there any ST segment depression in any of the leads except V1 or AVR? So ST depression in AVR is very common and nonspecific, so we're not going to look at it. ST depression in V1 can also be present in either STEMI or pericarditis, so forget those two leads. If you see ST segment depression in any of these other leads, you're done. You've got to call it a STEMI. And, well, sure enough, you do see ST segment depression in lead AVL, and in fact, maybe a little in V2, but I don't want you to have to imagine anything, so let's forget V2, but at the very least in lead AVL, you see ST segment depression. So we can essentially stop right there and call it a STEMI. We don't have to look at the EKG any further in terms of making this distinction, STEMI versus pericarditis. All right, but let's take this a few steps further. Anyway, the next thing that we've talked about is you take a look at leads 2 and 3 and compare them. If the ST elevation in 3 is greater than in 2, it's got to be a STEMI. And looking here, well, it's kind of too close to call. So you know what? Let's forget that. Let's go to that's not helpful. Is there a horizontal or tombstone type of ST segment elevation, right? If it's convex elevation, that can be anything. But if it's tombstone, that's got to be a STEMI. So let's go back and take a look. Is there a horizontal or tombstone type of elevation? Well, again, lead 2, that's kind of horizontal up there. Lead AVF is horizontal, maybe even a little tombstone-y, okay? Let's move over to the lateral leads. You've got horizontal. So there's another thing that's pushing us towards calling this let me get rid of some of this stuff here. We've got this as positive. We've got this as positive, saying that this has to be a STEMI. You're done. You don't have to look any further. We'll also talk about this other thing that we've talked about called the RT sign or the checkmark sign. Again, this is something that I've kind of made up, so you're not going to find this in the literature. And that also means that you take it with maybe a little grain of salt because I don't have big studies to back this up. But it's an observation that I've made over a number of years that when the patient has an R wave and then bang, it shoots right off into the T wave. I kind of overdid that, but let's say it shoots right off into the T wave and there's no ST segment at all. It just shoots right into the T wave, almost like there's a little check mark. All right, so I call it the check mark sign. And if you put your ear really close to the EKG, sometimes you can even hear it. It goes down and then bang. When you hear that bang, or when you see that R wave go right into the T wave, the RT sign or the check mark sign, that is very, very strongly an indication that you're looking at a STEMI as far as I'm concerned. All right. In fact, as far as I'm concerned, I'm going to call it a STEMI. All right. So let's take a look at the 12-lead EKG. Let's get rid of all this junk here. And again, it looks like we've got that check mark sign or the RT sign out there in V4. Bang! Put your ear next to the iPad or the iPhone. You'll see the R wave come down. Listen carefully. Bang! There it is again. So you've got a couple of leads here. In fact, taking a look in V3, you kind of see that also. All right. So you've got the RT sign or the check mark sign. And so let's see, we've got this saying it's a STEMI. We didn't need to look any further, but we did. We've said this is calling it a STEMI, and this is calling it a STEMI. And if you've got time to get serial EKGs and you don't care what happens to the patient, you get serial EKGs, you see Q waves developing, that's helpful also. Although we usually don't have time to wait to get serial EKGs for a few hours and look for Q waves to develop.
Thank you. That is our show for today. Next week, I have a very, very special guest. Going to be talking about vent settings. He's coming from very far, far away. So stay tuned.